Why does IBS start in one person but not another? Two people can eat the same food, face the same stress, but only one develops IBS. So what flips the switch? In this video, we'll break down the real IBS risk factors and connect each one to the mechanisms that make the gut hypersensitive, dysregulated, and reactive. To make this easier, we'll group the risk factors into 5 buckets: the body you start with, events that disturb the gut, daily triggers, lifestyle signals, and nervous system amplification. By the end, IBS will stop looking random and start looking predictable. I am Dr. Nushin. Let's decode it. The body you start with. Number 1, female sex. First one, being female. And yeah, the numbers back this up. IBS just shows up more in women. Why? 2 words, progesterone and estrogen. Progesterone relaxes smooth muscle in the intestines, so things move slower, literally slower transit. Estrogen does something sneakier. It ramps up gut sensitivity. It binds to L cells in the colon. Those cells release a signaling molecule called PYY, and PYY switches on the enterochromaffin cells to pump out serotonin. That serotonin activates pain fibers. So now normal bowel movements, something that shouldn't register as anything, actually hurts. And it doesn't stop there. These same 2 hormones talk directly to the gut-brain axis. Estrogen turns the volume up on that signal. Progesterone turns it down, partly by slowing motility, partly by calming the excitability of gut tissue through calcium channels. Even the microbiome gets pulled into this. Estrogen shapes which bacteria thrive, and when estrogen drops, that community shifts. But here is a twist. The microbiome shapes estrogen right back. There is an enzyme, beta-glucuronidase, made by healthy gut bacteria, and it reactivates estrogen so it can be reabsorbed. So dysbiosis can actually throw off your estrogen levels too. It's a loop. Hormones shape bacteria, bacteria shape hormones. Now, bottom line, every time these hormones shift during your cycle, pregnancy, menopause, all of it, that instability can light up IBS mechanisms. Risk factor number 2, younger age. Second one, and this one surprises people, younger age. You think a younger body would be more resilient, but actually it's the opposite here. Younger patients often have a more reactive gut-brain system. Their stress response circuits and microbiome are still more adaptable, but that also means they can be more easily disrupted by infection, stress, diet change, or antibiotics. In younger people, the brain's stress response system is still under construction, still maturing, so it reacts harder to stress and to changes in the environment. And the gut microbiome is in the same boat. This is still a work in progress, still finding its stable footing, which means it reacts more easily to disruption than a mature, settled ecosystem would. Risk factor number 3, genetic predisposition. Then there is genetics, and this one's not one gene, it's several different pathways that can each nudge you toward IBS. Variants affecting serotonin production, variants in genes that control cytokines, or the tight junction proteins holding your gut barrier together. Genes involved in mucus production, genes tied to the central nervous system, the HPA axis, and neurotransmitter signaling, and even genes regulating electrolyte channels. Different starting points, but same destination. A gut that is just wired to be more reactive genetically. Risk factor number 4, low birth weight or prematurity. This next one goes all the way back to birth. Low birth weight or prematurity. Incomplete gut maturation at birth means the intestinal motor patterns and the gut barrier itself are left less developed. And that sets the stage for IBS down the line. Perinatal stress, NICU exposure, feeding with something other than breast milk, antibiotics given to newborns, all of it shifts how the gut gets initially colonized with microbes. And early life hypoxia or undernutrition can affect mucosal barrier integrity and immune signaling, which ends up triggering reactive immune responses in the gut that carry forward. Events that injure or disturb the gut. Risk factor number 5, prior gastroenteritis. Now, this was huge in clinical practice. Prior gastroenteritis, a stomach bug that should have come and gone. Now, here's the thing. Sometimes infection leaves, but the gut and its nerves stay stuck in alert mode. We actually have a name for it, post-infectious IBS or PI-IBS. What's happening under the hood? The infection disrupts the tight junctions through cytokines, so the gut lining gets leakier, more permeable. That triggers inflammation, and inflammation makes pain fibers fire more easily. So the gut stays excitable, sensitive to totally normal things like stretching, long after the bug itself is gone. Motility takes a hit too. Mast cells release histamine and tryptase, which sensitizes nearby nerves, and transit can end up too fast, too slow, or just irregular. And on top of all of that, the infection can leave behind long-term dysbiosis. So really, one infection can trigger 3 of the 7 mechanisms at once: barrier, motility, and microbiome. Risk factor number 6, antibiotic exposure. Antibiotics, necessary, sometimes life-saving, but not without a cost to the gut. They don't discriminate. They wipe out the harmful bacteria, sure, but the beneficial ones too. And that instability is dysbiosis in real time. It gets worse if the antibiotics were given for a GI infection specifically, because now you're hitting a gut that is already inflamed, already off balance. Double hit. Risk factor number 7, gastrointestinal surgery. GI surgery can change the gut in 3 ways. It can disturb nerves, reshape anatomy, and disrupt the microbiome. Surgery can irritate the nerves that control gut function, and that alone can alter bowel habits. Scar tissue or changes in anatomy can damage the epithelium and the tight junctions, disrupting the barrier. Resections change transit time and shift the microbial makeup of the gut. Post-operative medications can shift things further. And don't forget the stress of surgery itself plus anesthesia. That combination messes with the CNS regulation, which disturbs the gut-brain axis and amplifies sensitivity on top of everything else. Inputs that keep triggering the gut. Risk factor number 8, food sensitivities or FODMAPs. Okay, food sensitivities, and this is where FODMAPs come in. Fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. These are short-chain carbs. Your small intestine isn't just equipped to absorb. You're missing the right enzymes or transporters. So they sit there. They pull in water by osmosis, and by the time they reach the colon, your bacteria go to work fermenting them. That produces hydrogen, methane, short-chain fatty acids, gas basically. Dissension follows, and motility and reflexes change in response. Think of it like this. In the small bowel, FODMAPs act like a sponge. In the large bowel, bacteria treat them like a buffet. What foods are we talking about? Oligosaccharides. Well, wheat, rye, onion, garlic, beans, and lentils. Disaccharides. That's lactose, so dairy, milk, yogurt, ice cream. Monosaccharides, fructose, found in fruits like apples, pears, cherries, peaches, and polyols. Sweeteners like sorbitol and mannitol, plus stone fruits like apricots, plums, nectarines, and also cauliflower. And if someone's microbiome is already altered, high FODMAP intake produces a different, often more inflammatory set of metabolites, including LPS, lipopolysaccharide, which can trigger mast cell activation, drive inflammation, and weaken the gut barrier even further. Risk factor number 9, unhealthy diet. Beyond FODMAPs, general diet quality plays its own role, and it hits from a few different angles. Diet triggers IBS through distension, motility changes, chemical irritation, and microbiome shifts. Fried and fatty meals slow digestion. The lipids trigger enteroendocrine signals that inhibit gastric emptying, and a bile has to work overtime to emulsify all that fat, which itself can provoke IBS symptoms. Processed foods, chips, cookies, fast food, bring along preservatives, dyes, thickeners, refined carbs. Your body doesn't absorb those well, so bacteria ferment them instead, pulling water into the gut and setting off symptoms. Sugary drinks pull water into the bowel too, speeding up transit. Low fiber is actually a double-edged sword. It can worsen IBS by slowing transit down, or it can ease it by reducing fermentation. Depends on a person and the solubility of the fiber. Spicy food, that's capsaicin directly stimulating pain fibers, irritating the gut and speeding things up. Caffeine stimulates motor contractions in the bowel and triggers acid secretion through bitter taste receptors in the stomach. And it can also amplify gut sensitivity indirectly through its effect on sleep and anxiety. Even roasted coffee specifically pushes gastrin release, which strengthens the gastrocolic reflex. And then alcohol speeds up transit and irritates the gut directly. Carbonated drinks are essentially swallowed CO2. More distension, more discomfort. Risk factor number 10, smoking. Smoking is next. Nicotine stimulates both the autonomic and enteric nervous system, which speeds up motility and transit, but it goes further. Tobacco smoke increases gut permeability by disrupting the junctions between cells, and it drives low-grade inflammation by altering mucin production and injuring the mucosa. Add in the hypoxia and cellular stress from smoking, and the epithelial cells themselves take damage. On top of that, smoking shifts the gut's pH, which lets certain bacterial strains overgrow while others get pushed out. Lifestyle signals to the gut-brain axis. Risk factor number 11, low physical activity. A sedentary lifestyle reduces vagal tone and shifts the autonomic nervous system towards sympathetic dominance, and that slows gut motility right down. Inactivity also nudges the microbiome toward a more inflammatory profile, tied to insulin resistance and metabolic changes. Meanwhile, exercise does the opposite. It improves motility and lets beneficial bacteria use more substrate, producing more short-chain fatty acids from fiber. There is a stress angle too. Less physical activity means higher baseline stress, driven by abnormal cortisol patterns. So the HPA axis becomes more reactive and slower to recover from stressors. That promotes a more inflammatory, more dysregulated state overall, and IBS symptoms worsen along with it. Risk factor number 12, sleep disturbances. Sleep. Poor sleep disrupts communication between brain and gut, and that shows up as hypervigilance and visceral hypersensitivity. It also pushes the body towards sympathetic dominance, which gets in the way of rest and digest mode. Poor sleep quality raises pro-inflammatory cytokines, contributing to low-grade immune activation, and it weakens your inhibitory pain pathways. So your pain threshold literally drops. Here is something people don't think about. The gut has its own circadian rhythm, controlled by the suprachiasmatic nucleus. It's got a body clock. That clock coordinates intestinal movement, digestion timing, even how sensitive the gut is at different points in that day. Disrupt sleep, and that rhythm gets thrown off. Contractions and secretions fall out of sync, and the gut ends up overreacting to stimuli it would normally handle just fine. Nervous system amplification. Risk factor number 13, anxiety, stress disorders. Now anxiety and stress disorders, and this connects to almost everything we've already covered. Chronic stress raises HPA activity and circulating CRF, which lowers pain threshold and sensitizes visceral nerves. So normal bowel movements start to feel painful. CRF is also tied to mast cell activation and changes in the gut barrier. Honestly, think of it as a stress messenger telling the gut directly to become more reactive. Anxiety shifts the nervous system toward fight or flight, which can speed up or slow down bowel movements depending on a person. It affects the enteric nervous system too, changing how the colon responds to normal digestion, and stress alters immune signaling and modulates serotonin release from EC cells. So both secretion and motility shift. Repeated anxiety drives central sensitization. More cortical attention gets paid to gut signals, visceral hypersensitivity increases, and everyday gut activity starts to feel genuinely uncomfortable. And this is where it gets circular. GI symptoms themselves increase worry and anxiety, which then feeds back into more gut dysfunction, a loop that keeps reinforcing itself. Risk factor number 14, depressive disorders. Depression and IBS feed each other too in their own cycle. When mood drops, serotonin pathways coming down from the brain change how the gut functions. Depression also drives low-grade inflammation in the gut through autonomic activation and immune cytokines, and it can disturb the gut lining directly. Here is a part I find genuinely fascinating. Depression changes how the brain notices gut sensations in the first place. Regions like the amygdala, the anterior insula, the anterior cingulate cortex, they're all more reactive in depression. So gut sensations get flagged as more threatening in the amygdala and amplified further in the anterior cingulate. Meanwhile, the prefrontal cortex, which is supposed to be the brake pedal, has reduced control, so it can't turn the alarm back down. And low mood activates body's stress system, tied to increased CRH and cortisol reactivity, which brings the same downstream effects we've talked about: more intestinal permeability, abnormal motility, and altered pain processing. Risk factor number 15, functional somatic syndromes. Last one, functional somatic syndromes. Fibromyalgia being the classic example. In these conditions, the responsiveness of central pain pathways goes up, so the pain threshold drops, and whatever pain does show up feels worse. Why? Because excitatory transmission gets stronger through NMDA receptor phosphorylation, producing a bigger pain response than the stimulus should warrant. At the same time, the inhibitory pathways, the GABAergic controls that are supposed to put the brakes on pain, they become dysfunctional. So the brakes just aren't there anymore. Then there is cross-sensitization, persistent pain coming from somatic tissue or from the gut, ends up triggering both visceral and somatic sensations in the central nervous system. And they start amplifying each other. Basically, Pain in one part of the body makes the nervous system more sensitive everywhere, so another region starts overreacting too. Ongoing gut discomfort keeps the spinal cord and brain on high alert, so even mild pressure on a muscle somewhere else ends up hurting more than it should. The nervous system becomes one shared amplifier for both gut pain and muscle pain. And that's 15 different doors that can lead back to the same 7 mechanisms we covered last time. Some genetic, some hormonal, some entirely about how you eat, move, or sleep. Next video, we're going where all of this actually leads, the symptoms and clinical presentation of IBS and how these mechanisms show up in the real patient in front of you. Once you've got this down, the clinical picture basically explains itself. See you there. So if you want to truly master medicine, not just memorize it, subscribe, and I'll see you in the next video.